good afternoon, everyone. I would like to begin by acknowledging that Concordia University is located on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters on which we gather today. Jokjoke or Montreal is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. I would now like to present our first speaker, Kate the Medeiros. Kate is a professor in the Department of Sociology and Anthropology here at Concordia University. She will be talking to us today about stigma, the environment, and the experience of aging. Just before I pass the mic, I would just like to ask everyone, if you have any questions, please enter them using the Q&A feature at the bottom of your screen. We will do our best to answer questions at the following of each presentation. So now I'll pass the mic over to our first speaker.
Thank you very much. So I'd like to first thank the organizers for inviting me to be part of this colloquium. I appreciate the opportunity. I would also like to clarify that when I'm using the word environment, I'm referring to the built and the social environment, which are the objects of interest of environmental gerontology and not the natural environment. So I apologize if that caused any confusion. So I want to first talk about age bias in general in healthcare outcomes. There's a growing body of research that suggests that outcomes for people based on age suffer because of ageist views about what it means to be growing older with a particular condition. So, for example, people may find themselves being told that, oh, it's just a part of old age, or, this isn't very serious, or not, their concerns not being taken seriously as it is for younger people. Physicians may be unwilling to run tests and so forth. There's also been a literature that links mental health outcomes, such as depression, to be higher in people who are older based on negative age biases. Again, increased incidence of depression based on environments where ageism is prevalent, and also ageism as experienced as with regards to life satisfaction. So there's a lot of literature, and more is coming. Now, I want to start also by thinking of places of age. So my whole point about talking about stigma in the environment. This comes from a survey in the US that found that from the 1,429 people ages 27 to 77, most of them said that they would rather die than live in a nursing home. Now, I bring that up not because of there's certainly issues that people have with nursing homes, but I bring it up because it's part of the social imaginary of when we think about places where people age. Social imaginary is what Chris Gilliard and Paul Higgs use. It's similar to the earlier term in British history, a green old age or sad decrepitude. So the third age and the fourth age is their way of distinguishing between living, that healthy, traveling, extravagant life, and then needing care. The fourth age as a social imaginary then becomes imbued with values of what we think about aging and what aging is going to be. So even though this isn't the reality for most people as they age, it's so ingrained in our everyday social imaginary that when we think of aging, we immediately think of nursing homes and people who are in need of a lot of care. Now, nursing homes, of course, are institutions, as Goffman described institutions. Those are places where the spheres of sleep and work are encompassed in one location. Large groups of people are treated in similar ways. Their activities follow under the guidance of whoever is the voice of authority. So, there might be some relatively small personal choices one can make, but really one's life is under the control of the institution to include what's available to eat, when one showers, when one dresses, who comes to visit and when, and so forth. And that's part of that social imaginary. And this is going to link then to what we think about environments of aging in general. So, again, keeping that social imaginary of the nursing home in the forefront and that notion of the fourth age. Now, interestingly, despite the fact that only about 4% of people in the US and similar rates in Canada, people over 65 live in nursing homes and about 2% live in assisted living, it becomes the predominant narrative. In fact, it's so pervasive that when I teach classes on aging, I actually have to threaten students. First of all, sometimes I'll put, no, nursing home is not the answer, or I threaten them not. I never really have taken points off, but if you say nursing home once again, I'm going to take points off. People conflate nursing homes with all sorts of living arrangements. Now, and it's partially because of this term old people's home. I hear this a lot too. I used to volunteer at the old folks home, or there's an old folks home up the road. An old folks home, this is just a definition I grabbed off the internet, is defined in this source as a place of residence where people are cared for. And again, this becomes a kind of pejorative label, just like nursing home, to refer to all sorts of places where people live. So, independent retirement communities, naturally occurring retirement communities where people who've lived in a particular area, generally apartments, have aged in place. So, this label gets attached, and somehow by calling it an old folks home or a nursing home, it others the people who live there. They're different. They're those failing bodies that we fear, that failing selves, the failing social capita. They're used as a very negative example of what happens as one goes through life, unfairly, I might add. So then the question that I'm interested in is, how are the environments where people are age stigmatized, and how does this lead to stigma by association? When we think about ageism is often approached as a personal thing. Research on ageism looks at personal outcomes. So, surveys and asking people if they've experienced ageism, if so, under what context, and then linking those personal experiences to health outcomes. So we see this in large panel data, coming out of many places in the world, actually. But I want to argue that it's also ageism by association to place. So that not only are we devaluing individuals, or individuals might experience this, but we as just the general society, view places of aging as stigmatized locations, and then view groups of older people as somehow less than or in need of. I pulled the a headline on the top just a couple days ago for my news feed. So we see phrases like silver tsunami that reinforce this negative idea. What are we going to do about housing? All kinds of things. There's also a growing number of resources online on how to combat ageism, how to say things when people make jokes about age, or say things like, I'm having a senior moment. Those sorts of things. And a recent initiative in the UK, there's an ageism quiz that emphasizes that words like sweet and cute, things like that, are actually very damaging. So even things that may seem to be, nice, like, oh, you look good for your age, are really microaggressions aimed at making people aware of the fact that they are aging, and somehow that's a bad thing. Now, again, in the context of health, aging people are more likely to be prescribed antidepressants rather than being referred to talk therapy. For one reason that was cited in a large study, it's because therapists view older people, particularly older women, who are the majority of people seeking mental health treatment in later life. They view older women as talking too much. So it's easier to prescribe somebody a medication than to engage in talk therapy. Again, based on a stereotype, that's not true. But that idea that there's a lonely widow who's just looking for someone to talk to, so, that's going to take up time in talk therapy. People who have beliefs, internalized beliefs that somehow their health is an inevitable part of aging are less willing to seek help for that. So if you've got, particular pains and you believe that, well, I'm just getting old, you may go underdiagnosed. And this happens a lot. I know personally I ran into somebody once whose mother was continuously misdiagnosed as she was just aging, and she finally got an accurate treatment, and it turned out she had blood cancer. So, this happens in the healthcare system, in many systems. 1 in 3 people age 50 and over believe they've been turned down for a job because of their age. So we see this, of course, in the employment sector, ageism, affecting all areas. And 1 in 5 employers believe that age discrimination actually occurs in the places where they work. So again, this uh, leads into negative health outcomes. So then that brings me to stigma. So stigma is that idea that you somehow have a spoiled identity or you're less than, that there's some quality that you as an individual have that is so devalued or so against the norm that it makes you different. And we can see this with ageist advertising, such as this, really focusing on, what would societally be viewed as negative. So somebody in a bikini who's clearly got wrinkles, who's showing signs of age, it becomes a joke. That goes into the general fiber of, social thought, and aging becomes something that's stigmatized and something to be avoided at all costs. Now, I add onto this the layer of environment because again, as I opened with, environments or, places, locations where older people live are subject to stigmatization because of age, which in turn leads to, stigmatization of place, which in turn, fuels this kind of negative perception. So when we think about place, we might think about place and home, and both are really complicated definitions because homes and places both can be geographical, they can be communities, they can be an affective emotion, they can be a memory, they can be an ideal. So you can have an ideal of home that's not a home you've ever lived in, but that you'd like to live in, or you can have a attachment to a place that you really identify with. So these become, again, complicated with aging. So just to go through some of the common understandings, sense of place are the emotions and behavioral patterns connected to a particular geographic environment. So your sense of place in your community, in your neighborhood, in your country, in your territory, province, um, you know, so place can be writ large or small. Then place attachment are the connections that you make between a place, potentially in a home. It could be related to the quality, it could be related to the emotional affect you feel. Now, interestingly, good residential quality is not equated with place attachment. So you can live in a place that's really dangerous or that you're in fear of or that you don't particularly like, but you still may identify with that place and it can have a really important part of how you view yourself. Place attachment is linked in some populations with better mental health, specifically lower levels of depression, but it depends. So it depends on where you are in that place. And if you're in that place because of choice or because of necessity or for other reasons. And so, with this place attachment, it's important to think about older people's worlds tend to be spatially circumscribed. So, for example, if you have lived in a neighborhood for a very long time and you are familiar with the stores, the people, places to get services, uh, if you start to need more assistance, if mobility or other things become more challenged, often place and familiarity can help fill that gap. However, on the converse, when we see things like gentrification occur and the common areas that people may have relied on and familiar and part of that place attachment change, we can see a flipped to negative outcomes. So when the coffee shop that you used to always get your coffee at now becomes a place that's no longer welcoming, maybe it's changed its layout. Maybe it's now playing music that is really loud or, unwelcoming to you. Then that can in turn lead to depression and higher negative mental health outcomes. So it's a really a little bit tricky. Place identity is social meaning, there's personal identity, and then there's external identity. So there's not only the sense how you identify. So you may identify in a vibrant city as being somebody who's, part of the ebb and flow of the day. However, others might identify you as something else, as a potential risk, as a potential threat. And so sometimes identity can be challenged. And again, that's part of that stigma that I'm thinking about in terms of ageism. A lot of times, too, when we think about identities, we do think about the insiders' perspectives, but not the outsiders. And I use these two. Who can be more offensive than The Simpsons? Their depiction of the Springfield Retirement Center, but then again, their depiction of the youth center. How others view people in these places and how they value or don't value people in these places is really important, but it's really, really understudied. So again, most of the work comes from the insider perspective, asking people how comfortable they are in a place, what they think about a place. Very little work done on how others view people. So how do you view the changing age in your neighborhood? Not a lot of work done on that. This also leads to, this phenomenon of spatial segregation, and there are a lot of debates on that. So when we segregate people by age, in some spheres, it's viewed as positive. So when people are sent to school, from, age 5 to 18 or whatever, that's age segregated. That's generally looked upon favorably. However, other kinds of age segregation, say for middle-aged people, is not so much. We think about age integration, but again, we think about age segregation in housing as a normative part of growing older. A lot of that comes from a long debunked theory, but impossible to get rid of. It's like the weed that you just can't kill in your garden. Is disengagement theory. So this was started in the 50s by a group interested in aging, and they theorized that people, as they age, naturally wanted to separate from society, and society naturally wanted them to separate so that they could make room for people to replace them. And so, age segregation also went hand in hand with this, right? It's natural that you're going to want to go and live in a place with other people like you and kind of out of the way where we can't see you, so we can get on with the day to day existence of, work and family and other things. It's like I say, it's long been refuted, but is immortal and refuses to die. So this idea, does age segregation reduce stigma? Well, interestingly, within living communities, there's often a lot of stigma that residents might have against others, usually based on ableist uh, views. So people who have assisted devices are not typically welcome by groups of people who don't. People who move up to levels of care that are higher often aren't visited by people who are living independently. Now, I think that certainly, as all housing choices should be a choice. So I'm not suggesting that age segregated housing is bad for people who want to live there, but I'm also suggesting it's not the answer to everything. Um, in the US, about 10% of people age 65 live in age segregated housing. So this could include subsidized housing for people over 50. This could include independent living, this really hyper expensive retirement communities. However, the fiercer the competition for space, the higher the occurrence of age segregation. So as property becomes valuable, as housing becomes scarce, age segregation increases, and often not in areas that are desirable. So often, age segregated housing, at least in the US, is built in places that are not deemed desirable commercially or residentially by other businesses. Now, looking at age segregation, then spatial age segregation has been associated, albeit weakly, with poor mental health. And part of the question becomes it's a chicken and the egg. Did people age segregate because of their health, or did age segregation lead to that? So, again, not a very clear answer there. But lack of age diversity in a community has been highly suggested to contribute to ageism. So if older people are not integrated into communities, if all ages aren't represented, it's easy to view older people as other and therefore hold ageist beliefs. So in thinking about this, it's really, really crucial that we pay attention to the stigma of place. So are we attributing all places that older people live with this deep-seated fear of the nursing home? And that leads us in turn to have behaviors that want to separate us from them. But again, this applies to retirement communities. And as I've mentioned, if I had a dime for every time I had a student say, "Oh, so and so lives in a nursing home," well, no, that's actually a very expensive, independent living, community. But that's the pervasive thought. Then that negative perceptions on aging leads to negative health outcomes through that external ageism, which translates to internal ageism. So the more people tell you, that and fill you with negative aspects of your condition. So you're old, you shouldn't be doing that. You're too old for that. Of course, you're going to be depressed. You're old. The more you internalize that, the more it becomes a reality. This is thinking of age stigma in environments and how they apply to individual experience with ageism and with health outcomes is a very, very new and understudied area of research. I hope to take this up in much greater detail. And I would invite anyone who might be in the audience who has an interest in this to please reach out, because I would love to get something much more robust going to really take some of these issues and look at them from a place perspective. So thank you.
you, Kate, for the wonderful talk. So I just want to remind our audience that if you do have any questions, please enter them using the Q&A feature at the bottom of your screen. I think your talk might have been very clear. I don't see any questions. So what we're going to do is we're going to move on to our second speaker. And if anyone has any questions, again, just enter them using the Q&A feature, and we'll get to them at the end of the second talk as well. So now I would like to present our next speaker, Kim Sawchuk. Kim is a professor in the Department of Communication Studies here at Concordia University and holds the Concordia University Research Chair in Mobile Media Studies. Kim is also the director of Engage, Center for Research on Aging, Montreal, and the ACT Lab, Aging Communications and Technology Lab. So now over to Kim.
Need to unmute. Speaking of digital care work, I'd like to echo Kate's thanks to you all for being here this morning and for being invited to give this talk. Can everyone see my screen? Good.
Yeah.
All right. So the title of my talk today is Digital Care Work. So I just want to provide a bit of context for where this work has been generated from for the past few years. As mentioned, I direct something called ACT, which stands for Aging Communication Technologies. It was a SSHRC-sponsored major partnership grant with many people. And it was an early exploration of what does it mean to experience aging and later life in an increasingly digital world. And there were 3 axes to this project. And so the research that I'm going to talk about today, much of it was generated as a result of being engaged with the ACT project over a number of years and has continued on as I've moved into new projects that have to do with the ways that older age and life is quantified, but also datafied. And that's the Aging and Data Project. So as we know, I actually started out when I started doing work on age and aging saying that I don't do health research, and I deliberately don't do health research or research related to health and aging because so often much of the research on aging has to do always with health. And there's a kind of, in my field, I think, a kind of understanding that if you're talking about old age, you must be either talking about health or other issues that, in fact, a lot of people wanted to talk about other things. And so in 2009, I launched a project called Seniors and Cells, which was about cell phone culture and the transition from landlines to cellular technology or mobile phones within the context of Canada. And at that time, the research group that we kind of assembled were doing work that kind of wasn't being done so much within gerontology and gerontology or socio-geron technology, because there's been a predominant focus when I would talk about technologies, everybody was thinking I was talking about health technology. I'm a communication studies scholar. I study ICTs and what it means to live in a digital world. Now, of course, COVID-19 changed all of this for better and for worse for many, many people. And a lot more people have become involved in this landscape of research on digital technologies in everyday life and what it means to age. Some of the projects that we did that I'm going to refer to in passing today that we conducted, a lot of them, of course, because of the segregation we had to lived in our homes in order to avoid the contagion moving further, and because of public regulations, means that we found other ways to do research with older adults, indeed finding ways to collaborate with community organizations and other partner organizations who realized that suddenly many older adults didn't have access to digital technologies, or if they did, they maybe didn't have access to the internet, because there's an assumption that if you own a device, that means you automatically have some way of making it hook up to a network. Many older adults use libraries or other public spaces. When you can't go out, you don't have access to them. So we launched a number of projects, including one with Health Age Canada that distributed tablets to older adults and community organizations across the country. And we conducted evaluations of how those projects were going. We worked with the Montreal Museum of Fine Arts as they launched a virtual museum project that was really interesting, that happened once a week, that was supposed to be about actually showing how museums could provide better health outcomes for people. We weren't doing the health research, we were doing the qualitative work on people's responses to having this kind of program delivered online. We launched a grocery project with New Hope for Seniors in NDG because there was an assumption that a lot of older adults in Montreal knew how to access grocery stores online, had the credit card or the means to do so. And indeed, their Meals on Wheels programs were again canned during this time, as was their group grocery shopping. So they were concerned about food insecurity. So what do? We went back and created a bank of volunteers and used the telephone to reach people who were digitally disconnected. Post-COVID, we've been working with Shannon Hebblethwaite. I've been working with Shannon Hebblethwaite, Megan Joy, as well as Tracy Swim for the WIN Intergenerational Center on a project called Impulsions that has been interviewing members of community organizations about their experiences during COVID. And also with Clairgesse, we conducted post-COVID pilot interviews with managers, staff, and residents committees in long-term care environments about how they understood the residencies were actually going to have to or were changing as a result of the incorporation of digital technologies in various ways into their organizations. And so for someone who said she never did work with medical communities or practitioners, suddenly I found myself increasingly asked to participate in projects with the medical community who are keen to find as well telehealth digital solutions to problems facing older adults seeking access to healthcare. We know this is across Quebec, but I primarily work in Montreal, where there is a shortage of family doctors. And this brings me to the topic of today, digital care work, which is the idea, what do I mean by this? Well, my research question is, how does living and aging in a digitally networked society transform relations of care? What do I mean by care? I draw on the work of Joan Toronto, who writes that care is a species activity that includes everything we do to maintain, continue, and repair our world so that we may live as well as possible. That world includes our bodies, ourselves, and our environment, all of which seek to interweave in a complex life-sustaining web. And it's worth noting that Toronto is actually a political scientist who thinks that thinking about politics through the lens of care may actually help us to reshape democratic politics. In this little tiny book, but she has a much longer book that I'm not going to refer to today, Toronto talks about 4 kind of valences of care, 4 ways to think about care that articulate a relationship to others or oneself even. And these moments are caring about, which is the task of defining needs, caring for, which entails accepting responsibility and realizing something needs to be done, caregiving or acknowledging care requires work, and then care receiving, which requires looking at a situation, the resources at hand, and that are assigned to improve it, and asking if indeed the identified need has been met. So I'm going to use these 4 moments as a way to describe what I mean by trying to do research on digital care work and rethink the notion of care via Toronto as a way to sort of insert this question that I have about what does it mean to age within a digitally mediated society. Other research questions, and this is where there's some connection, I think, helpfully to the work of Kate that you've just heard, which is where is care located and who does it? So for me, some locations of care include the research that's happening in, and I use the word geriatric medicine because some of the people I work with refer to themselves as geriatric doctors who are trying to find digital solutions to the crisis in healthcare delivery, to formal care settings such as long-term care environments, some with nursing and formally trained care worker staff that are trying to create better efficiencies in operations and provide better care. And digital technologies are often used, the language of what we call in media studies, the digital sublime. Efficiencies are often used as a kind of buzzword for why it's going to be better, as well as quality of life. Informal settings, such as the home, where older adults may be living relatively independently, but may need some assistance. And I think here again, in thinking of care and assistance, it's important to remember that we all have and need assistance throughout our lives. This is not just something that's a part of aging, but there are specific assistance needs that may come as we age that we need to take care of. And finally, there's the third sector of care, which is an area that I've been very concerned with for many years, which is the kind of work that is done in the non-for-profit sector as well as by community organizations who do a lot of care work, but it's never defined as necessarily as such. So digital care work, 1, caring about. Toronto talks about it as a complicated task of defining needs. And here I want to point to the work of Bischoff and Yake, who have written this wonderful article called Configuring the Older Adult, and it's about the design of geron technologies or technologies that are specifically targeted to older populations. And they note that most of these projects are still focused on producing innovative digital artifacts rather than geron technology, which is embedded in the experiences and practicalities of older people's life worlds and relationships. And that's someone, as an age studies researcher who comes from a communications background, we're very interested in is the experiences and practicalities of the life world and the relations and how they're affected by the introduction of technologies into these worlds. Digital care work, what does it mean to care about? Well, again, the complicated task of defining needs means one must ask, what are the communicational needs? Not just needs. We're not just needs-based beings. We have desires. And how are they defined by older adults? Is there a digital solution? And if so, then what is it? This means identifying who the stakeholders are in a project, in a community, and thinking about individual consultation or group consultation, not just at the beginning, but throughout a project. And most of all, remembering that if these technologies are being developed for older adults, consulting with them, genuinely consulting with them, is paramount. Digital care work is also about caring for. As Toronto says, it means entailing and accepting responsibility and realizing something needs to be done. And here I'm pointing to 3 projects we've done that work from the micro level to the macro level where digital care work was involved. We worked in HLMs on introducing Wi-Fi into the HLM common rooms at a certain point. But what that meant is when we did workshops and people were invited to come in to do one-on-one consultations with interns who we trained, there was every story on hand from, I can't find a password because my wife has died and she had all the passwords. Can you help me reset this computer? Often many of them old. And these developed into kind of wonderful relations of care that entailed not just skills in terms of digital knowledge, but also a kind of skill, people skill that was required in order to meet the desires, needs, and the listening that was actually needed in these situations where people often divulged, really, really heart-breaking stories or wanted to share the joys of their life, which meant the conversations often flowed in directions that had nothing to do with the technology, but were extraordinarily important in establishing relationships and making people feel a comfort in the digital learning environment. We've worked with organizations like Respecting Elders, Communities Against Abuse, helping them develop their website, trying to give them training on maintaining it, but also creating projects because many community organizations have found that since getting rid of money to organizations in terms of core funding, that if they put technology in the title of their project, they can often find funding. So finding ways to kind of accomplish your core mandate, but satisfy funders who are looking for some kind of digital solution, but that makes sense for your community is a challenge. And this Food Talks series of discussions on food insecurity launched by RECA, which was also a recipe sharing exchange because they come from many cultural communities, was a good example of that at a kind of meso level of care work. And then finally, with, again, organizations like RECA and Seniors Action Quebec, we've done policy submissions to the government, Canada, the Radio and Telecommunications Commission, to talk about the high costs of Wi-Fi and cellular services in our country and how this deleteriously affects older adults' ability to continue to access digital services after retirement. So these are ways of accepting responsibility, realizing that something needs to be done at kind of very different levels, where I think different forms of addressing access to digital technology and also entails a kind of care work. Identifying barriers, there's this nice model from communication studies called the Access Rainbow model, which makes all of these issues of identifying needs and digital needs as if it can be like sliced out like a rainbow, when our experience has been it's more like a bowl of spaghetti that's really mixed up together. And once you start to take one strand off the bowl, all the other strands start to untangle and unravel. And it's much more complicated and interrelated. So digital care work also entails caregiving in Toronto's schema, acknowledging that care requires work. There's really fantastic older anthropological feminist sociology like Meg Luxton's book from the 1980s called More Than a Labor of Love, where she interviewed working class women in the town of Flin Flon, Manitoba, my home province, about the introduction of washing machines into the environment and how it transformed their practices of socialization. And she has a fantastic chapter that talked about the way that talking about kind of the labors that these women were doing in the home as an act and a labor of love also diminished and devalued the kind of work that was involved in maintaining the home. So I think there's a really important connection here between that really early work from the 80s that was about a whole other set of technologies and their introductions into the home, with the kind of idea that technology doesn't itself require care. And this is a really fairly large preoccupation of mine, which is what is digital caregiving and what does it mean to care give in a digital age? What it requires is work and expertise, training and experience. It means us asking who is providing assistance. It means asking who's paid and unpaid in terms of the provision of this labor. There's a term in media studies called warm experts, which is often used to describe the work that you yourselves may do, helping and assisting others. Answer questions like, is this app safe to unload? And why is my internet so slow? And should I give my credit card? And should I update my computer? And why is my printer not working, etc.? Digital care work means that we have to acknowledge that digital devices don't take care of themselves. This is a picture of a drawer I have in my home of things that I don't know what to do with, but I'm scared to throw out. Digital technologies are not inert. They're kind of more like a garden, and they need pruning, and they don't take care of themselves. And so introducing digital devices into a person's life you may think it's a really good thing, but it also means that it requires constant maintenance, upgrading, and other hidden costs, including time to learn, maintain, but as well, space. Also, we have data and statistics on the cost of what it means to have digital access in Canada, which is extremely important because when we do the kind of user testing that often happens around access to digital technologies, especially when we go to online surveys, we're already surveying people who are in a fairly high socioeconomic bracket who are aging. And that in post-retirement worlds, this is really related to gender, it's related to immigration, it's related to issues around race, and all the other forms of discriminations that live in our society. It means that quite often in post-retirement worlds, the kind of costs of maintaining digital access can be exorbitant for people. Some people we've interviewed have to choose between groceries, medications, and connectivity. So digital care work is also about the act of thinking about care receiving, which is also about how do we evaluate projects that we may embark upon. And I'm going to just quickly run through an example before I head into my conclusion. I worked with some researchers at Colloquium where they were trying to develop a web application to provide early on health assessments to people. It was called CARE, ironically, and it was supposed to give you ideas about whether you had health problems in advance of going to see a doctor. And it would sort of talk about problems with memory, physical health, mobility, and nutrition. I won't go through these images. I did not select them. I was not consulted about the app. I was there to evaluate it. So we conducted semi-directed interviews based on 30 questionnaires with people who were pre-testing as well as 4 focus groups. And the feedback we got was extremely interesting because we found that people found the questionnaire did not have sufficient context about their lives to make an assessment. When there was a mismatch between what they perceived as their health outcomes and what they were being told was a problem that they should go had a neurocognitive potential issue lurking in their future. They assumed that the problem was with the test, not with themselves. And they often took the test multiple times to get the results that they thought matched their perceptions, which we thought was extremely interesting. But again, back to the question of caregiving, some of the specific feedback we got was from caregiver participants. So in all but one instance, the caregivers commented that they took on the task or the work of filling out this questionnaire. So something that was intended for a particular individual to kind of do an assessment of themselves over time ended up being extra work for caregivers who already felt overburdened because of the work they do. But as well, what they pointed out was that the so-called digital solution also assumed that there was a solution out there in the real world for them, that if they took this test, found they had something to worry about, that they would have access to being able to go to a doctor or consult a nurse or get into a treatment center. Whereas the experience was that perhaps this is what needs to be changed. So in conclusion, if we care, the questions that I have as a media studies researcher who's looking at the kind of nexus of the ways that digital technologies are entering into different location environments or locations of care is thinking about this question, which is, do our digital solutions impose a new role onto caregivers who end up mediating, in this case, telehealth encounters? That's a point made by the researcher Nellie Utzschorn in her wonderful book, Telecare Technologies and the Transformation of Healthcare, a study in the use of ECG machines, where Utzschorn talked about the transformation of people who would have considered themselves as patients receiving care into diagnostic agents, which created a new form of responsibility for themselves in terms of healthcare self-management, which sometimes is desirable, but which is not always possible. Are we prescribing to promote these kind of solutions to promote what sociologists call the responsibilization of problems that may need support publicly onto older adults and caregivers through the digital. For example, in a system with a critical lack of family doctor and health and social services for older adults, is the digital solution always kind of the be all and end all? But I don't want to dismiss it, but ask what role can it actually play and should it play responsibly? Finally, what are the other forms of assistance that are needed to integrate such solutions from into the life world and daily routines of older adults with care? So I take from Ocean this idea that care technologies are transforming our subjectivities as we age, and that we need to pay attention to this. I'm thinking about digital care work as being hand in hand with the development of strategies that need to empower older adults and not simply force us to become digital, which we call forced mediatization, but as well finding ways to value the expertise at a social and political level of those who become digital care workers. Now, of course, informal digital care work is always going to happen, but what we found when we worked for Health Age, for example, was that people who had actual training played a really important role in terms of helping to mediate, as well as the assumption often with informal care work is that people have access to people who can help them when many older individuals may, in fact, live alone. And where do they go? So these skills, as I say, are not merely technical, but also may come from experience outside of the tech realm. In fact, our study with Help Age was very interesting because the people who were the best tech mentors at providing assistance for older adults to do remote learning actually had worked in the service sector as waiters and waitresses who were then unemployed, who were looking for other employment. They had developed the people skills and patience and an understanding of flexibility and a whole variety of what we call soft skills that were important to being a good tech mentor. But also what we have to think about is the way these can be gendered. And we have to ask ourselves in the broader picture of IT and digital care work, who's being paid vast sums of money for tech development and who's being paid not vast sums of money for this kind of digital tech care work at the ground level. So thank you. And I'd like to thank my team, the government for helping to furnish this, as well as the community organizations who've been a part of this project.
Wonderful. Thank you so much, Kim. So we're going to go to some questions now. I do see a few that were entered. Just to remind the audience again, if you do have any questions, please enter them using the Q&A feature at the bottom of the screen. I believe our first question was for Kate. So the question is, I was wondering if you considered interviewing young people who have parents and grandparents living in nursing homes and visiting them regularly, that you would give a different perspective potentially.
Yeah, I think it's important to have voices of people from all aspects. It doesn't align with my research questions, so but I do think it's important. I find often too, having worked in long-term care, that people's perceptions of what happens in long-term care are very different. And again, it's another source of information, but not really aligned with my particular questions. So no, I had not pursued that.
Thank you. So the next is a comment more than a question, but I think it's a nice one. So I'm going to read it. So this is from one of our attendees who says that I'm going to be 89 in June. My next door neighbor, who has been in Canada for 2 months from Ukraine, kept telling me how cute I am. I don't mind that at all. No one said anything like that when I was a child. Um, so that was just the comments. I could probably see myself feeling that way when I'm older. Another sort of comment question from another attendee. Sad that the concept of care being discussed does not include self-care. Instead, elderly people are seen as being recipients of care. What about applying digital technologies to provide self-care tools, enabling do-it-yourself approaches to all sorts of issues facing not only seniors, but other groups as well?
Yeah, I'll answer that one. First, yeah, I think, can you read the question again? I just want to, because I think there's actually two parts to that question that I want to address.
Yes. So, said that the concept of care being discussed does not include self care. Instead, elderly people are seen as being recipients of care. And what about applying digital technology to provide self care tools, enabling do it yourself approaches to all sorts of issues facing not only seniors, but other groups as well?
Okay, first, I want to say that older adults are not just recipients of care. And that's one of the things we think about at our lab is that the reciprocity of care means that older adults are often caregiving throughout their lives in many different ways, helping not just themselves, but helping others from family members to friends to volunteering in their communities. So again, in terms of thinking of those care relationships, I think like Kate, there's a kind of misunderstanding of the way that care functions in our society so that as you age, you're seen as the recipient of care, when in fact, you're often older adults are doing a lot of care work. And indeed, that's the case with people who are caregivers for people who are sick is often it's a spouse or a friend who themselves is often older, who is involved in having to do the care work that's involved when digital systems are put into place. I do think that there is a role and a place for do it yourself ways of self care and management. But I'd also say that what one needs to think about is a whole series of questions about things like informed consent. So if you have an Apple Watch or a Fitbit, who are you engaging with to take care of? Who's getting the information and have you consented to having your data, for example, taken from you? The idea of self care is extraordinarily important, but also so is the idea that at certain points we may not be able to only take care of ourselves. Technologies change throughout time, and at a certain point, people have to decide how much more technology can I introduce into my life, and can I actually afford to keep purchasing it, especially if it is or is not covered under certain kinds of healthcare plans. So I think that the issue of do it yourself is something that, of course, I engage with myself. I want to take care of myself and manage my health as much as possible. But I think my point is that throughout the life course, we all require assistance at certain moment. And also that where I come from, studying media and communications technology, what I see more and more is more investments into the development of technological tools and gadgets and money going there, and not enough money going into the other end of the spectrum, which is what happens when it's delivered into an organization. Is it being evaluated? Is it a gadget that works and needs to be maintained? Who does the upgrading of that technology? What happens if it is hacked? Who's going to ensure that your identity is not taken from you or that you have a problem with your banking information? So we're involved in a really complex and complicated world of technology where, frankly, no one can do it by themselves anymore. I can't. We rely on others with different levels of expertise to help us out. And that's my point.
Thank you, Kim. Next, we have a question for Kate. Well, to both of you, it says, thanks for the presentation. A question for Kate. With respect to the spoiled identity family members of people living in long term care experience, what are some of the ways that you address the popular notion that a move into long term care is always an expression of a family not caring? The health status of the older adult is not considered. This is a belief that I spend a great deal of energy trying to dispel in a class.
It's true. There's this idea that somewhere in the world, there's this mythical place where families love everyone and people live happily ever after and everybody's great. And that simply doesn't exist anywhere. One thing that I really stress to people is that, the social and the opportunities for being in a community in assisted living or nursing home are real and they're very, very important. So care isn't so much just the delivery of meals, of assistance with medicine, of other things, but people can spend all day by themselves, especially if they've got working family members, and that's not a failing of the family. It's just a situation that is unsustainable. I think that there are so many opportunities for people to live really good lives in assisted living and in nursing homes. And I find that, having, worked and done a lot of research in these places, sometimes what people see on the outside is not what happens on the inside. So somebody comes into a care facility and they think, oh no, it's so sad. I just see people, they're in there for a very short period of time. They don't see people laughing. They don't see the friendships that get formed. They don't see the social opportunities. I've also seen families get burnt out caregiving and leading to a whole host of other problems, and of family members themselves not wanting to be cared by their family. They don't want their daughter to bathe them. They want to be in a place where they, know that that's that person, that's what they're there for. That their social time with their daughter is social time. So I think people have to really get beyond that idea that there's this mythical, time when we ever cared the way that people think. They'll say people don't care about their families anymore. Intimacy at a distance has always been the preference in Western culture. In Eastern cultures, often there are issues about who has to provide care, usually the daughter-in-law. So, I think that it's a whole area to open up and not just rely on these stereotypes that we think exist.
Great, thank you. We have another question for Kim here. Will this app be redeveloped in such a way that it will provide resources to save time for caregivers as a goal? And secondly, become integrated with follow-up appointments with nurses, doctors, etc.
Yeah, I think that would be a long-term goal, would be to say that if there is something that you self-diagnose, in a sense, that there is a potential for you to be able to get an appointment, but we're not at that place yet, unfortunately. I mean, it demands a whole other, it's not just a single app that can do anything at all. The other thing is that apps are a lot of work for technologists to maintain, because we have changes in our operating systems, and with digital devices now being what we would call assemblages and networked, it means you might have a watch that's connected to a phone, that's connected to a computer. Anything can go awry at any one of those, but also people have different devices they're more comfortable using. So in the case of the tool that was being developed, um, the caregivers were also taking care of people who had some problems with cognitive issues, but also who sometimes just found things like, like no matter how big you make the buttons, they're not the right size for me. I can't press this. But also some skepticism about this, and also others feeling like what happens if you get a diagnosis that tells you something and you're on your own, and you're in a situation where you might be alone. So I think that the kind of development of this app kind of raises a whole host of questions about the ethics and politics of diagnoses online through an algorithm that also is assessing the information you give. It's not being made by a person, it's being made by an algorithm that's kind of outputting an answer. And so I think I know that they've decided that, what we learned from this, and this is, I think, what good researchers do, is, this seemed like a great idea on paper. We tried to develop it. Then we tested it with older adults and in caregiving situations in different types of environments that people who are older and might need this live in. And they told us that, it overburdened them. It was too much work, and they didn't find it as useful, and the response is overly general. And if they couldn't get access to a healthcare provider anyway, why do this? It would just create more worry in their lives. So I think these are really, again, interesting kind of questions. And what they've decided now is they're going to try and develop an app that is kind of like a chat bot that would be a virtual assistant that you would do. I'm curious to know how that would work. And other questions that come to mind is when I'm trying to get assistance, for example, to contact my telecommunications provider because my internet is down and I get a virtual assistant. I try and get out of that virtual assistant as quickly as possible because I find I never really get the answers to my questions. And I'm wondering whether these kind of chatbots are just another version of what I would have called telephone answering hell that you would get in, where you had to press 1, 2, 3, 4, 5 to find the right response or person to finally talk to. So again, I think that if these systems can make communications more efficient, if they can triage people into systems better, I'm all for it. But there's certain points at which I'm not completely, when one has to ask, Where are the other people with what expertise who then need to be talked to in the end? And are these just ways of creating more barriers for access, or are they enabling them? And so this is the kind of things that communication scholars research in collaboration with tech developers and older adults.
Thank you. So I realize we're a little over time, but we have one more question for each of you. So the next question for Kate. Can you expand on the place identity concept? Please, is it necessary that the concept be connected only with senior house or care centers?
Yeah, no. So the second part, no, it's not necessarily connected with senior health or care centers. It's just a broad concept that describes how a person identifies themselves with a given place. So your place identity could come from your neighborhood, it could come from your city, from your university, from your work, from a lot of different areas. And I was linking it to particularly to care facilities, just to suggest that sometimes outsiders make assumptions about the people in those places. Who are these people? They stereotype them. Often people don't identify themselves with living in places like that. Again, it's not that they're bad places or they don't have a lot to offer. It just gets back to that whole social value system that is frightened of care, basically. So,
Thank you. And our last question, and for Kim, I'm wondering how you are reaching out to OA to participate in workshops that you mentioned. Also, who has access to labs workshops? Does marginalized OA have access to it? And thank you so much for the beautiful and informative presentation.
Thank you so much. Yeah, I mean, I'm one person who hires students to a large extent to try and manage projects. But come to us. I think I left my email in the at my last slide, but certainly if you signed up for this, Wendy can send it to you. How do we do outreach? We work collaboratively with community organizations who either service older adults directly or indirectly. For example, we just had an event for Black History Month last week that we worked with the Depot in NDG, with Women on the Rise, and with the West End Intergenerational Network. That was a beautiful roundtable on storytelling. And we're having a workshop, which we are calling Joy Shops now, because we don't expect people to work and we want people to have fun. It's being put on by Warsami Issei, who's an MA student who's doing work on music and is for himself from Somalia, is interested in African diasporic music, and is interested in the music that people of all ages might like. And so we invite you to come to that. It's this Thursday from 6, I think it's from 4 to 6. It's free. It's on the 6th floor of the ER building, 2155 Guy Street, and we can send you the details to that. We work with Respecting Elders Communities Against Abuse. We send out information through Perform. We work with Yellow Door. We work with Atwater Library and Computer Center. Outreach is always a challenge, and that is one of the difficult. We've worked also with Montreal, the City of Montreal, trying to develop projects in places called HLMs where people on low income might live. We've also brought our surveys and our research to shopping malls and I've set myself up as a researcher in a secondhand shop at one point. So sometimes it's also about thinking, where can we make research happen? At Loyola, we have a project we've been doing that's a continuation of the grocery project with New Hope. That's a living lab, which is actually 2 gardens, one with accessible gardening beds and one that's a little bit lower, but depending on your mobilities and interests, it's places where students and older adults are invited to come, and what you garden, you get to take home. And we're developing a project as well about seeing whether or not we can reseed, literally, vegetables that are discarded at the end of the shopping day using a passive hydroponic method. So we reach out through any means we can, snowball methods through Senior Actions Quebec. But if you're interested in any of our projects, you can contact Wendy or myself, Engage, or the ACT Lab. And And we post our stuff all the time now, with more frequency at the Concordia website. So we know, and we learned this working with New Hope, that, and it's a problem for all community organizations, is that they're staffed by people who care a great deal, but who are often really underpaid and often are female. And if you're suddenly find yourself as a young person in having a child, you may go in and out of that work environment. So there can be a lot of turnover in these environments because of the demands of it. And that's why I personally care so much about people who are working, providing what we don't think of as care, but who are actually really important, I think, members of what I would call the overall care community in Montreal, who I think do fantastic work, but who themselves will talk very genuinely about the ways that outreach can be difficult, especially for those who are digitally disconnected, since so much of our outreach now assumes everybody is. So these are ongoing challenges that I have no perfect answer to, and all you can do is do your best and get as many people on board as possible and create events that people want to come to that are fun and interesting.
Great. Well, thank you so much. So we are out of time now. So I just want to thank both of our speakers for the wonderful talks, and thank you to everyone for attending. The recording will be posted on the School of Health website shortly, maybe in a couple days. So to everyone, just have a great afternoon. And thank you.